Welcome to the Hormone Optimizing Warrior MD, your reliable and trusted source for information on hormone therapy for menopause and beyond, and on how to advance into the second half of your life with confidence and optimism, knowing your hormones are optimized and balanced with everything else in your body. Whether it is hormone therapy, peptide therapy, laser therapy, or some other new technology applicable to maintaining our vitality, mental and physical strength, you will hear all about it in this podcast. Welcome to the last chapter on osteoporosis. As promised, this episode is going to be all about the osteoporosis big pharma FDA-approved medications that are available on the market. It's going to be a detailed discussions of how they work, the pros and cons, their limitations, and their side effects, as well as the very possible dangerous consequences for a woman's health that come with the use of some of these drugs. These are all things you should consider every time someone tells you have to be on any medication, especially if you have to be on that medication for a very long time. Anything over a year is a very long time. So I'm going to dive right into it. In order to understand the osteoporosis drugs designed to specifically improve osteoporosis and where they are unable to help and why they might cause harm over years of use, it is important to understand the machinery or the mechanisms that they are interrupting or manipulating. Every FDA-approved medication for osteoporosis that is mass-produced will work by interfering with one lever or another in the bone signaling system that the body already has operating in the background. None of these drugs are biologically active by themselves, but they amplify, they block, or they mimic a biological process that is, again, constantly running for the body. Now, picture a bone as a construction site that is permanently open and permanently has a crew building that project. Cranes are always disassembling old, fatigued material. Those are the osteoclasts. They have the main job of destroying and removing old, weakened, and fatigued bone, while a separate crew, the osteoblasts, will come behind the osteoclasts and pour fresh material, replacing the old with the new, the weakened bone with stronger, healthier bone. If you didn't know, in a healthy adult skeleton, about 10% of the bone tissue is constantly being replaced at any given moment. Just this slow motion renovation that's constantly going on in the background. Now, osteoporosis is what happens when your demolition crew starts outpacing the construction crew. The disassembly continues as scheduled, so the osteoclasts continue to remove old and weakened bone, but the rebuilding is not up to par. It falls behind. The osteoblasts are not active enough. And guess what? They are going to be lazier as a woman enters menopause and loses estrogen. And the bone structure becomes more porous. It is thinning. So the internal scaffolding is going to be weaker and thinner. The bones become fragile enough that a fall from standing height can fracture a hip, or a hard sneeze can fracture a spine bone, a vertebrae. In women, this shift towards bone loss and excessive bone remodeling with destruction will accelerate pretty sharply and specifically around menopause, which is why the disease of osteoporosis is so often discussed as an aging problem, because it happens as you enter menopause and it's ongoing as you move further and further away from menopause into older age. All the osteoporosis medications act on very specific levers of this process. It is important when you make a decision about a certain class of medication that you understand what that medication does and what lever is specifically influencing. So the body has this very simple renovation machinery involving 3 different types of cells. I talked about them before. You need a reminder, or if this is a new topic to you, this is 1 minute, very quick. The body has these 3 different types of cells. The osteoblasts, which lay down new bone and mineralize it. The osteoclasts, which dissolve old bone. And the osteocytes, which are walled-in osteoblasts that have walked into the bone that they built, and they sit inside the finished bone like a sensor, monitoring the mechanical strain and the chemical signals. And guess what? They decide where remodeling needs to happen next. So, osteoclasts, osteoblasts, and osteocytes. The communication between these 3 types of cells is running through 2 different pathways. And this is new information I haven't talked about before because I didn't need to. But now that I'm talking about all these drugs and what they do and how they influence your body, you need to know this to understand how these drugs work. The first pathway is called the RANKL/RANK/OPG pathway. I know it's a mouthful. It's spelled RANKL/RANK/OPG. This pathway runs the demolition, the destruction of old bone. Let me explain and give you a little bit more detail about this. Both osteoblasts and osteocytes produce a signaling protein called RANKL, RANKL. And this protein binds to a receptor called RANK, RANK, on the surface of the osteoclast younger cells, is telling them to mature and to start resorbing bone. So the osteoblasts and osteocytes produce RANKL. It links to RANK, its receptor on the surface of the osteoclasts, telling them to activate and start destroying bone. So when RANKL binds to the RANK receptors, bone loss can increase. The osteoblasts and osteocytes also produced OPG, also known as osteoprotegerin. This is a natural protein existent in the bones that helps protect them from excessive resorption by the osteoclasts. It's that lever that balances the RANKL. It acts like a brake, is the exact opposing lever of RANKL-RANK activation. OPG maintains the balance of osteoclast activity and keeps it under control. OPG literally sits in the bone environment and grabs onto the signaling protein called RANKL. And when the signaling molecule is bound by OPG, it cannot bind the RANK receptors, so the signaling for bone destruction is reduced. As a consequence, the bone resorption will slow down. This is very important because there are very specific medications that play in this box and influence these very specific proteins involved in this pathway. The second pathway is called the WNT beta-catenin pathway, which runs the rebuilding, the new bone formation. The activation of this pathway is all about osteoblasts and the signaling that gets them to work to form new bone. WNT signals are growth messages for bone-building cells. And due to the signaling, osteoblasts are activated. The WNT protein acts like a key that fits into a receptor on the surface of the osteoblast. Once this key fits into the receptor, a chain reaction starts inside the cell that leads to the stabilization of the molecular structure for a protein called beta-catenin, C-A-T-E-N-I-N. This protein is now able to go into the osteoblast nucleus, the control center for any cell, and helps turn on the genes that are telling the osteoblast to multiply and to start making new bone. Remember I told you before that osteocytes are osteoblasts that are walled into the bone. They act like sensors, and they decide when and where bone remodeling needs to happen? Well, osteocytes can also restrain the bone formation pathway by producing a protein called sclerostin, which blocks the WNT signaling and acts as a brake on bone formation. This brake is released only when the osteocytes decide that new bone formation is needed. This is important because there are medications that inhibit this protein called sclerostin, and this can help build bone more effectively because it's letting the WNT signaling protein to do its job of activating the osteoblasts. And layered over both of these circuits is a woman's estrogen. And that's important because we're talking about osteoporosis in women because this is a major problem for aging women and it happens after menopause. Now, estrogen suppresses the rankle production. Remember, that's the signaling protein that activates osteoclasts to destroy old bone. So estrogen can act as a brake on bone destruction. Estrogen also boosts OPG. OPG is the protein that exists in the bone tissue, which helps protect osteocytes from being destroyed. OPG is the opposing lever of rankle, and estrogen strengthens this lever in the favor of bone formation. This is how estrogen protects your existing bone. Estrogen can also dampen the inflammatory signals that recruit osteoclasts, so it can diminish that type of inflammation. And overall, estrogen will tilt the whole bone remodeling system towards preservation. That's why nothing works like estrogen in nature. Once women lose estrogen at menopause, it is the single biggest reason why they start losing bone mass much faster than aging men or premenopausal women. The loss of estrogen will loosen the brake on the destructive processes within the bone. The rankle activity, activating osteoclasts, versus OPG, is in the favor of osteoclast activation. So the rankle system is overpowering the OPG, which is the protector. So the demolition crew gets both bigger and a little crazier, less supervised. Maybe they're drinking on the job. So now that I laid the foundation that you need to have in order to understand all the medication I'm going to talk about, let's talk about the first class of medication that's called bisphosphonates. This class includes alendronate, risendronate, ibandronate, and zoledronic acid. All of them are oral except for zoledronic acid, which I believe is injectable. This is the oldest and still the most widely prescribed class of osteoporosis drugs. This class of drugs works by slowing down the demolition crew at a molecular level. The biphosphonate molecule structurally resembles something called pyrophosphate. This is a natural component of the bone mineral. So the biphosphonates bind avidly to the calcium-rich surface of the bone, especially the bone surfaces that are actively being resorbed, attacked, destroyed. When an osteoclast comes along and ingests a piece of the biphosphonate-coated bone, it will absorb the drug along with it. Once inside the osteoclasts, the biphosphonate will mess with the internal function of the osteoclast and impact its ability to attach to the bone and do its job. Then the osteoclast loses its ability to function and will die an early death. So, the mechanism of action for biphosphonates is poisoning the osteoclast cells directly, instead of adjusting the rankle-OPG ratio as estrogen does in a gentle, nice, natural manner. So one of the downsides of this treatment is the fact that the biphosphonates bind very tightly to the bone mineral and they don't get eliminated from the bone quickly enough. Sometimes not for a decade down the road. And this is a very unusually long pharmacological effect for a simple oral medication that needs to be taken daily, like Fosamax, or weekly, like Boniva. This persistence of biphosphonate within the bone could be why they're so effective at increasing bone density, but it's also what creates a significant danger. In the short term and the medium term, the biphosphonate therapy reliably increases bone mineral density and reduces hip fracture, spine fracture, and wrist fracture risk. guess what? They're very inexpensive and they're available to be taken as a daily pill or a weekly pill. But because remodeling isn't just about preventing fracture, it's also about the mechanism. And you know that the skeleton needs to repair every day micro damages in order to stay strong. Unfortunately, the profound suppression of osteoclastic activity for years can leave old, weakened, and fatigued bone in place much longer than the body needs. So your bone density looks better on the test, but it's because it has a lot of old, weakened bone. There are two well-documented and very significant long-term complications from the use of this drug. Osteonecrosis of the jaw, in which a segment of the jawbone, which it's interesting to probably say at this point in the podcast, that our jawbone has a much faster turnover than the rest of our body, especially when there are dental extractions or implant surgery. So as it turns out, this specific segment of this jawbone fails to heal because the local remodeling is being suppressed too effectively by the biphosphonate therapy. So the body is not fast enough in repairing the weakened and fatigued bone on time. So osteonecrosis of the jaw, it's a serious, serious thing, but luckily is rare. The other long-term complication is a atypical femoral fracture. So you're trying to prevent a hip fracture, but you can get a low femur fracture. These are very rare, but often women can suffer bilateral stress fractures down the thigh bone, which can occur with minimal trauma after years of continuous therapy. Also thought to happen because the unremodeled bone caused by the biphosphonate use accumulate. So micro cracks that are not properly repaired will eventually culminate into a full fracture. Now, both of these complications, the osteonecrosis of the jaw and the atypical femur fracture, are rare, about 1 in 1,000 after about 5 years of continued use. But the risk continues to rise steadily if you use biphosphonates for more than 5 years. So a woman who is using biphosphonates is now recommended to take a drug holiday after 3 to 5 years. And apparently stopping the therapy has actually reduced substantially the risk of these types of fractures. Another much more common, not as dramatic, consequence of this type of therapy with biphosphonates is the risk of esophageal irritation. That's why it's highly inconvenient, but women are told to stay upright for 30 to 60 minutes after swallowing the pill, and that is important. Now, remember when I talked about estrogen influencing the 2 pathways of bone remodeling? I told you that it does this in a natural way, and it's really the body's own logic at work. So if I were to be given the choice between biphosphonate therapy use and estrogen, I would certainly choose estrogen. And when it comes to me recommending it over biphosphonates, I would definitely do that unless there's a major contraindication to the use of estrogen. The second class of medications are called RANKL inhibitors. Remember the rank OPG pathway I talked about earlier? That's why I talked about it, because you need to understand what this class of drugs do. These medications are called denosumab, I don't know if I'm pronouncing it right, or denosumab, or Prolia. This medication is a monoclonal antibody. It works further upstream than the biphosphonates. Remember I told you the biphosphonates actually poison the osteoclasts and inhibit them. So once the osteoclasts are formed, they die and they don't do their job. Well, the Prolia binds the RANKL signaling protein directly, and it prevents it from reaching the RANK receptor on the osteoclast precursors. Essentially, Prolia is a pharmaceutical mimicker of OPG because it does exactly what OPG, the osteoprotegerine, would actually do naturally to keep bone resorption in check. But Prolia does it synthetically and far more powerfully. Prolia is given as an injection twice a year. every 6 months. It's injected subcutaneous under the skin. Very easy. Your doctor sends the prescription to your pharmacy. The pharmacy delivers to the doctor's office. You come in, you get the shot, you walk away, you get the shot again in 6 months. It acts on the rankle protein. Since it doesn't bind to the bone mineral like the bisphosphonates, its effect is fully reversible and clears from the system 6 months from the last injection. Well, it might sound an advantage over the biphosphonate resilience of remember, years or decades, right? It doesn't have the build-up drug reservoir that the biphosphonates do once they're ingested, and it doesn't last that long of a time. But this turns out to be possibly one of their main hazards. Remember I told you that it mimics OPG? It does so in a synthetic, far more powerful way. And as it turns out, when the therapy stops or the dose is delayed by more than a month or two, the rankle signaling doesn't just return to baseline, it overshoots. And now the osteoclasts precursors that have been held in reserve for 6 months, maybe even 2 years, are now released all at once. So bone turnover markers spike way before they might have been at pretreatment levels. And unfortunately, bone density can fall rapidly, producing a significantly documented rebound destruction effect on the bone. That includes a very significant risk of multiple fractures within 12 to 18 months of stopping Prolia. On top of this, the rankle signaling molecule plays a role in the body's immune system, signaling immune cells as well. So blocking the rankle pathway has body-wide effects that are beyond limited to the bone. And it can also increase the risk of hypocalcemia, specifically in patients with kidney problems. Again, this specific lever of the rankle pathway is very, let's call it elegantly influenced and controlled by estrogen. Why mess with Mother Nature and ask for trouble? Probably only when there's a major contraindication to estrogen. Or when the doctor convinces you that you should get Prolia and you don't know anything about it, you say yes, you're like, oh yeah, okay, every 6 months, it's easy, not a problem, let's do it. So keep in mind, there are some serious consequences to using Prolia, and there's a rebound risk of fractures when the treatment is stopped. So ask, what's the plan when I stop Prolia? The third class of medications approved for osteoporosis treatment is called selective estrogen receptor modulators, or SERMs, SERMS. The main drug in this class is raloxifene, spelled RALOXIFENE. The mechanism of action for this medication is delivering a molecule that binds to the estrogen receptor, behaving like an estrogen in some tissues, and on the other hand, it's also behaving as an estrogen blocker in other tissues. This is very typical of what I call an estrogen receptor disruptor. Raloxifene, also known as Evista, EVISTA, acts as an estrogen agonist and behaves like estrogen into the bone tissue, so it inhibits osteoclast activity by modulating the rankle OPG pathway, very similar to how estrogen does it, and by doing so reduces the risk for fractures quite meaningfully. This type of medication, again, was approved in 1997, marketed as Evista. But tamoxifen is used in breast cancer treatment. Now, as opposed to tamoxifen, who's also somewhat of a SERM, raloxifene acts as an estrogen antagonist, which is a blocker in both the breast and the uterine tissues, which is actually valuable to a very specific category of women, perhaps those with breast cancer, because it modestly reduces breast cancer risk while improving bone density. Now, on top of the fact that this medication's ultimate impact on bone is only a fraction of the actual benefit on the bone density that estrogen has, because this is a much weaker estrogen modulator, it also increases the bone density much less than biphosphonates and carries with it one of the oral estrogen's most dangerous properties, an increased risk of thromboembolism. So there are the risks of DVT, pulmonary embolism, or other cardiovascular problems because estrogen receptor activation in the liver will alter the clotting factor production. Remember, this medication is taken orally as well. On top of this, hot flashes or leg cramps are very common and significant complaints for patients who use it. But raloxifene does not have the long-term risk of osteonecrosis of the jaw or fractures of the femur that are seen with the other two categories of drugs I mentioned earlier. It doesn't have an increased risk of rebound fractures when it's stopped because it does not inhibit the osteoclast activities as powerfully as the other two classes of drugs. Now, class 4 is calcitonin. This is a hormone normally produced by the thyroid that inhibits osteoclast activity directly through its own receptor, which exists on the osteoclast cellular surface. This is a very, very small lever. It acts like a brake on the bone reception, and this lever works alongside OPG and estrogen. Calcitonin is usually administered as a nasal spray or an injection, and it modestly increases the bone density. It does have some pain-relieving benefits in women who suffer acute spinal fractures, and this is actually its main clinical use. Long-term, the reduction in fracture risk is not that high. It's much weaker. And because there's a long-term trial that linked calcitonin use with a small increased risk of cancer, this specific treatment has prompted European regulators to restrict long-term use. And it went to the back of the line when it comes to the algorithm of osteoporosis prescription. It remains FDA approved in the United States, but again, it's reserved for patients who cannot tolerate other options. So I just decided I'm going to mention it here so you know about it. In case your doctor recommends it, you're going to be like, why calcitonin? There are much more powerful other things that FDA approved. Why this one? So always ask. The next class includes anabolic agents. Those are medications that are telling the body to build bone. Every other class that we talked about so far is anti-resorptive. It prevents and messes with the destruction process of the bone, slowing the natural destruction of the bone, supposedly allowing the new bone formation that occurs naturally, uninfluenced by anything, to catch up passively. The drugs in this category are teriparatide, also called Forteo, Forteo, or abaloparatide, called Tymlos, Tymlos. These are synthetic molecular fragments that are related to the structure of the parathyroid hormone. They both work by exploiting a very interesting paradox encountered in the parathyroid hormone physiology, which I mentioned before in another episode, but I'm going to remind you today. This is the fact that continuously elevated parathyroid hormone will cause bone loss, but the opposite is seen with intermittent, elevated, pulsed parathyroid hormone exposure. So in other words, too much parathyroid hormone release from the parathyroid glands that's consistent and steady will cause osteoporosis by excessively mobilizing calcium and leaching it from the bone, therefore weakening the bone matrix and increasing the risk of osteoporosis and bone fractures. I explained in my podcast episode when I talked about osteoporosis causes, and I explained this mechanism. These medications, Forteo and Tymlos, are given as a once-a-day injection, so they will do the opposite, will stimulate osteoblast activity and new bone formation by briefly spiking the parathyroid hormone signaling. And then because this is very short-lived, the body reads the pulse, the surge release in parathyroid exposure as a formation signal, stimulating osteoblast activity. Yes, there is a significant clinical payoff, as these are the only drugs on the market that build new bone, rather than just preserving what the body already has or just inhibiting the destruction pathways as the other drugs are doing. Anabolic agents produce larger bone mass density improvements compared to the anti-resorptive medications, especially when it comes to the spine. However, there's always a however. Sustained exposure to roughly 18 to 24 months stops working, stops activating, and more so in a series of rodent studies conducted with high and prolonged doses of these two anabolic molecular hormones, there have been cases of osteosarcoma, a very rare bone cancer. So far, this hasn't been confirmed in the much shorter courses used in clinical human trials, but the FDA mandates a lifetime treatment cap for both of these medications of 2 years. There has to be a strategy and an exit plan for post-treatment because the bone density gain from this type of therapy will fade very quickly after stopping the drug. So you have to follow through with some anti-resorptive medication or something else like estrogen to help maintain the new bone that was formed. Both of these medications have injection site reactions, nausea, cramps, dizziness. Occasionally, they might cause high calcium levels or very low phosphate levels, which can by themselves have other consequences. And these medications are not suitable for patients with pre-existent risk factors for bone cancer, like Paget's disease or patients with unexplained elevated levels of alkaline phosphatase. This is a 2-year temporary stay of execution when it comes to osteoporosis. This is not a long-term solution. I have one more class of medications, and that is the sclerostin inhibitors. This is interfering with the mechanism that suppresses bone formation. At the beginning of the episode, when I talked about the two pathways, I told you that the osteocytes can also restrain the bone formation pathway by producing a protein called sclerostin that blocks the WNT signaling, acting like a brake on bone formation. This brake is released only when the osteocytes decide that new bone formation is needed. This brake on the bone formation system can be released by the drug called romosozumab. That's a mouthful, but this is the newest and the most distinctive class of medications approved in 2019, and the brand name for it's Evenity, Evenity. This is a monoclonal antibody, just the same as Prolia, that binds and neutralizes the sclerostin directly, releasing this brake on bone formation. It unblocks the WNT activation of bone formation, and it decreases bone resorption, as sclerostin itself promotes rankle expression, which is the osteoclast activation pathway. So this gives Evenity a very interesting dual action mechanism, which is capable of producing the fastest and the largest bone density improvement, with the largest bone density gains seen in the first year of treatment compared to any other approved osteoporosis drug on the market. So this is the most powerful drug on the market that we have right now. Now, here's the downside. There's always a downside. After about 1 year of this bone stimulation effect, the body's biofeedback system around the sclerostin brake adapts, which is why the treatment needs to be stopped after 1 year. And like the other anabolic agents I mentioned earlier, it must be followed by another medication, specifically an anti-resorptive medication, to preserve the improvement in bone density and to prevent further bone loss. What are the serious consequences of using this medication? Well, apparently, this medication has a serious cardiovascular risk. And it does carry a black box warning, which is the worst warning an FDA can designate a medication, is the risk of heart attack, stroke, and sudden cardiovascular death. So your bones are going to be stronger, but you might die. That's a little scary. Now, this medication is actually contraindicated for anyone that had a heart attack or a stroke in the 12 months preceding the consideration for its use. It would probably be common sense to make sure that the cardiovascular risk is assessed for anyone when they want to consider Evenity. Maybe do a calcium score to see if you have plaque in your heart. Maybe do a lipid profile with inflammation markers, and definitely monitor blood pressure and other markers regularly to understand whether you have a blood vessel disease risk while on this treatment. Let's close this chapter on osteoporosis because this was the last drug, thank God, by thinking a little bit about what all these drugs are doing. They are tinkering with the body's natural mechanism of bone remodeling. Now, the body's already doing a great job as long as it has estrogen, and it does it without a prescription. Every single one of the interventions that I told you in this episode, every single one of these drugs is a workaround for the fact that estrogen has declined and for the fact that the mechanical signal for the bone is insufficient, or the nutritional intake of protein and mineral nutrient isn't enough on its own to keep bone formation and bone destruction in favor of bone formation. Here are some closing takeaways. The natural levers of bone remodeling balance are still operating in every woman, whether they have estrogen or not, and whether they decide to use medication or not. And very often, these natural levers will determine how well estrogen therapy for menopause or for osteoporosis will work, or how well any other therapy for osteoporosis will work. These two levers I'm talking about are mechanical loading, which is the most literal example of use it or use it application in medicine, because the sensors for mechanical load in the bone do not distinguish between a 20-year-old or an 80-year-old. They simply respond to strain. That is why weight-bearing aerobic activity like walking, stair climbing, dancing, jumping, running, etc., and resistance training combined together will improve bone density regardless of age. And on top of that, this is one of the few interventions that can also improve balance and muscle strength at the same time. And remember, this matters greatly because most osteoporosis fractures at old age happen because someone falls because they're weak and have poor balance. They don't fall because their bones are osteoporotic. They fall and they break a bone because they lost muscle mass and have poor balance. And now because their bones are osteoporotic, they break the bone. So doing activities that promote balance and muscle strength are significantly increasing your protection from fractures and improving your bone density. And just to clarify that, no drug I mentioned in this podcast episode will do that for you. This is something you have to do for yourself. The other lever I'm talking about is mineral and nutrient and protein intake. This is a very important limiting factor and the basis and the foundation of any osteoporosis treatment. Consider the fact that calcium is the building block of hydroxyapatite, which is the mineral phase of the bone. And without dietary or supplemental calcium, enough to meet the body's needs of about 1,000 milligrams per day for most postmenopausal women, and ideally, this should come from food, not from supplements. Without this, the body will have to pull calcium out of your skeleton to maintain the blood calcium levels, regardless of what the drug that you're taking for osteoporosis is going to do to slow osteoporosis down. So if you take a medication for osteoporosis, even if it's estrogen, Evenity, Forteo, Prolia, bisphosphonates, it doesn't matter. Your body's ability to build bone will be limited, and both the medication or estrogen or both, if you're doing both, will have an underwhelming performance. And the final result, when you go to do the repeat bone density test, will be disappointing. So you need calcium. Remember, you also need vitamin D for calcium absorption in the intestine. And without vitamin D, a large amount of calcium is likely to be wasted, unabsorbed, and eliminated, pooped out into your stool. So finally, when we look at all these medication classes side by side, we start to see a pattern. Biphosphonates like Fosamax and Prolia will slow down bone destruction, but by different means, and they have different end-of-treatment problems. Biphosphonates linger in the bone, and the risk of over-suppression of the bone destruction is significant, while Prolia clears quickly, but has a significant rebound increased fracture risk when you stop it. Raloxifene or Evista and estrogen itself activate the estrogen receptor. Evista does so very narrowly and incompletely. Estrogen activates estrogen receptors in the bone fully, but you can trade bone density improvement and comprehensive hormone restoration and balance for possibly increased risk of cancer and increased risk of cardiovascular events, which, as it turns out, when it comes to estrogen, is not as bad as we thought, and definitely not as bad as we were told. The anabolic agents like Prolia and Evenity try to make the body build new bone rather than just conserve the bone it has, but they all run into the same problem. The biological signal they interfere with is self-limited by design, which is why every drug in this class is very limited in duration of treatment and requires a handoff, a follow-through to either Prolia or bisphosphonates as a must-follow with a second step. Now, underneath all this, you have the human body's own natural and very glamorous machinery of mechanical loading, which is exercise, and the mineral supply provided by a bone health-focused diet, which no drug and no hormone in the world will replace, and which every single medication in this podcast episode I talked about will depend on in order for it to work in the first place. So whatever drug you decide you want to use, consider the fact that none of them are a replacement for the foundation of diet and exercise, and possibly much needed hormone support. However, for a woman who has already fractured a hip, a vertebrae, a foot, or a wrist with very small trauma, the truth is that the risk reduction for a future fracture that these medications I talked about will provide is something that diet and exercise, even combined with hormones alone, cannot replicate. And that's where and when these drugs might prove to be invaluable. Remember that the best use of any drugs when it comes to managing the bone remodeling construction site project, analogy I used at the beginning of the podcast episode, is the goal to nudge the bone remodeling back into balance, not to override it indefinitely. It is entirely possible that a 60-plus-year-old woman can improve and significantly cure osteoporosis by eating healthy, a bone-focused diet, exercising well, and considering balancing her anabolic hormones, if applicable to her situation, instead of resorting to all the drugs I mentioned above and their possible risks, side effects, and complications. Do not be afraid of weightlifting. Remember, mechanical load, it's a pillar for bone health. But if you're considering weightlifting, which you should, do it as long as you have it done with supervision, with a trained professional, especially when you have developed osteoporosis. Again, don't do this at home watching a TV or having someone in your ear virtually telling you what to do. Someone has to watch your form to tell you in detail how to tighten up your core, how to lift the weight, how to focus on certain parts of your body, how to adjust your stance, etc. And ultimately, when it doesn't look right, tell you to stop in order to avoid injury. I hope this episode was useful. And if you're one of my patients that doesn't know what to do and what drug to choose, I hope this episode is going to help you decide on what is the best path for you. Thank you for the time and energy you spent listening to my podcast. If this episode or another have caught your attention and delivered valuable information you have not heard anywhere else, and if you feel I have succeeded in my mission to provide the how to stay healthy and age beautifully, please leave me a review. And any suggestion to improve the podcast will help make it better for you and for others. You can send my staff a message directly by sending an email to receptionist@herahealthcare.info.